Thank you, Doug. Good morning, everybody. Excited to be here. Thank you for having me. Happy to kick off this event. This is a great event. How many people here are experts on the upcoming healthcare legislation? Good, because I plan on making up a lot of this as I go along, so I can get away with a lot. I speak on this subject quite often, and I have to say it never gets easy. It's a very challenging subject to speak about, and for a few reasons. One of the reasons is it is a pretty boring subject, right? I mean, we're talking about 2,000 plus pages of legislation written by a bunch of politicians, right? It's not very exciting, but secondly, and probably the most challenging thing about speaking on this subject is that, it's 2,000 plus pages of legislation. And trying to encapsulate everything in about 50 minutes and have everybody feel like they walk away understanding everything is extremely challenging. So, you really have to be careful about what you leave out and what you add, and make sure that, you cover everything you need to cover. But also, too, it's a very polarizing subject. I bet if that I asked for a show of hands in here on how everybody felt about this, we'd have hands going up and down all over the place about, how they felt about different aspects of legislation. So if you're not careful, you can end up making everybody mad in the room by the time you're done. So, having said that, today we're going to stick with three things. One is that we're going to be, first and foremost, that I'm going to be as objective as possible and keep my opinions to myself, as difficult as that may be. And second is that we are going to stay more big picture, just due in the interest of time, mostly that we're just not going to have enough time to get into a lot of details. We will get into some, but not a whole lot. And third, we're going to focus more on the future. There's been a number of guidelines and regulations that have already been put in place, and we're not going to spend a lot of time on those. I have one slide, actually, that we're just going to look at and kind of go over to give everyone an idea of what's going on. But those are things that are already done, put in place. We're living those. Everyone should already know about those. When we are going over them, if anybody sees anything that raises a red flag for them, please feel free to come to me afterwards and ask. I'm more than happy to help. But we're really going to focus more on the future of healthcare and what's coming up, because that's really the meat and potatoes of what's coming up in this legislation. The big ticket items are just around the corner, so that's what we're going to focus on. So having said that, let's go ahead and jump right into this thing and get started from the beginning. So, right, the good old days. It used to just be 50, 60 years ago. You got sick, called the doctor, they came to your house, they brought a little bag. They treated you, you gave them a little money, and they walked out the door, right? Very simple. Well, things have changed quite a bit, right? Just in the last 50, 60 years. We've had wonderful advances in technology that we've all benefited from, or we've known people that have benefited from it as well. But it's made things a lot more complicated, and it's also made things a lot more expensive. In 1950, the average American spent about $100 a year on health care, which is about $500 in today's dollars. In 2010, that number was $8,400 a year. It's a huge jump. And the price in the future, it just keeps going up, right? Well, why? I get in this conversation a lot with people, and I'm sure you probably have too, and you have a lot of times will say, well, all we have to do is this, or all we have to do is that. If we just did this, then it would help them solve the situation. Well, it's not that simple. It's a complicated problem, and there's a lot of moving parts. And so this next slide here is just to kind of illustrate to everybody just kind of how complex and involved the issue really is. First and foremost, 1/3 of the country is obese. We have a health issue in this country. We're not the healthiest country in the world, and it's getting worse. And regardless of whether we like it or not, we're all in this together. We all share in the costs. When people are driving up huge claims and spending a lot of money, we all share in that to some degree. So, that's a big part of why we're seeing healthcare costs go up. Increased technology, like you saw in the previous slide. We've had wonderful advances in medicine, but that comes at a price as well. Lawsuits, preventive medicine, you've heard about tort reform. We actually have that here in Texas, but a lot of states don't. But a lot of doctors practice preventive medicine, and they do things that aren't necessarily necessary, but they do them to cover themselves, and that ends up driving costs that we all end up having to share in. Advances in medicine, like prescriptions. There's a pill for everything now, and these pills are expensive and costly, and, we all pay the price for that, and shared premiums. Lack of transparency. No one knows what anything costs, so prices are artificially high as a result. Without us knowing really the true cost of what we're paying for when we go to the doctor or the hospital, that helps drive up prices artificially. Free riders. There's a number of people in this country without insurance. They go to the emergency room. They don't pay the bill. We all end up having to pay for the cost of that. Treating symptoms and not causes, and we're all guilty of this, you have something go wrong with you, and instead of taking care of the reason, we take a pill, have a procedure, do whatever, and that ends up driving up costs as well. Abuse of the ER. I read recently that 17% of all ER visits are necessary. That means 83% of them aren't. And the average cost of an ER visit's over $1,000, and a doctor visit's about $50, $60. So you can imagine, too, that's also a cost driver as well. Government regulation, this bill. A lot of people are always happy when they hear that their insurance companies are required to do certain things, and they're always usually happy to acquiesce and do whatever they say because they just pass that on in the form of higher premiums. So we all end up having to pay for that. And a good example is preventive care is now covered at 100%. And you probably hear the politicians talking a lot about this that are promoting the new bill. Well, yes, it's covered at 100% at the time that you have your services done, but that's just factored back in the form of your premium. So you're just paying for it in the form of higher premiums. So every time the insurance companies and businesses and everybody are required to do something, that's just passed on in the form of higher cost to you. Inefficiencies and duplications. Are we the most efficient system in the world? No. If we were more efficient, could we save money? Yes. And then aging demographic. We have a huge segment of this population turning older, and as they do, they're higher utilizers, and that's driving up the cost of claims, and we all share the cost of that. So, not to spend a whole lot of time on this, but just want to give everyone an idea of the complexity of what we're dealing with, that there is no magic bullet, one solution that's just going to solve everything. So I think everyone in the country could agree that we've been on this unsustainable path of cost, right? Costs just keep going up and up. More and more people are uninsured, fewer and fewer businesses are offering coverage, and no one's really done anything. Not us as a people, no one's, or health insurance companies or hospitals, no one's really stepped up and had any real significant impact on what's going on. So everybody knows what happened, right? The government stepped in, and this is what we got. And I love this slide because the first time I saw it, I was like, this encapsulates exactly how I feel every time I see and have to deal with this legislation. It is a monstrosity, and it's very complicated. And for those of you who can't read the caption at the bottom, Obama's standing there with a construction worker with a set of blueprints, and he says, maybe I should have been a little more specific. What is it? It's the Patient Protection Affordable Care Act. PPACA, Affordable Care Act, ACA, the number of acronyms and names, Obamacare, whatever you want to call it. It's a bill that was signed into law in March of 2010. It's over 2,000 pages, and over 1,000 times it says the Secretary shall determine, or something similar to that nature, where basically they're leaving it up to Health and Human Services or some other department to clarify the regulations and basically say exactly what needs to happen. So there's a lot of gray area in the bill. It's funded by approximately $500 billion in tax increases and $500 billion in Medicare cuts over 10 years. Now, I put a plus after that $500 billion in Medicare cuts because I think if y'all have been following politics and everything recently, that's up to $700 billion now. I know it's a shocker that, it's not exactly what they forecasted, the numbers. And the cuts is that there's some debate on what a cut is. And, that's a subject for another time, but there are going to be cuts in Medicare in certain areas to pay for this bill. The primary focus is to decrease the number of uninsured in this country. It's not to address cost or anything of that nature. It's primarily just to get the number of Americans, is it 30 million? Yeah, 30 million down off of the rolls and into insurance. There's multiple new regulations on the health insurance carriers. There's the individual and employer mandates, insurance exchanges, community rating for small employers and individuals, which is a big deal. And this is all phased in over 8 years, and the majority in the next 4. Or over the first 4, I should say. So as you can imagine, the last 2 years for us and for businesses have been overwhelming. Because over that 1,000+ times where it says the Secretary shall determine the last couple of years, we've just had a number of rulings and guidelines established and them coming out and saying this is what it is. But there's been a number of occasions where once they've established a guideline, they've gone back and changed it because they determined it wasn't feasible. So we've been constantly, we have compliance attorneys at our office, and they constantly are following this stuff and issuing bulletins and trying to keep all of our clients and employers up to date, and it's been an extreme challenge for everybody, and it's been pretty frustrating in the process. As you remember, there's a number of court challenges, right? And the big deal is the individual mandate on this thing. States challenged the constitutionality of it. It was split. It went to the appeals courts. There was mixed results in There's mixed results in the appeals court, and then the Supreme Court said go, right? They said it's a tax. It's not a penalty. The mandate is constitutional. It's a tax. So what we know now, these are all the things that they've ruled on and established guidelines on. Everything from the age 26 requirement, making insurance companies cover dependents to age 26, to W-2 reporting requirements for employers, basically having to report the cost of the employees' benefits on their W-2s, to FSA limits for individuals, flexible spending accounts, not being able to put more than $2,500 in there. So we've just had a number and a series of regulations and guidelines that have been established that everybody's having to abide by. It seems like a lot, but there's much more to come. So what is coming? Well, the big stuff is coming. The individual mandate, the employer mandate, community rating, the private and public exchanges, pre-existing conditions and guarantee issue for everybody, the Cadillac tax, and then there's a few others, and these are all tax increases, or as everyone in Washington likes to call revenue generators. The comparative and effective research fee, the Medicare tax increase, the Part D subsidy drug elimination, and itemized medical expense deduction changes. So, starting with the individual mandate, this is the one that got all the attention, right? Basically, what is the individual mandate? What does it mean? Well, basically it means that everyone has to get minimum essential coverage. They have to buy a major medical plan. Well, what is minimum essential coverage? Well, it's virtually all group health plans. The government said basically that right now about 98% of all group health plans out there meet the minimum essential coverage requirement. Virtually all other benefits, so individual policies, Medicare, Medicaid, CHIP, VA, TRICARE, state risk pools, and anything else Health and Human Services says is minimum essential coverage. What does it not include? There's accepted benefits, and basically it's anything like accident, disability policies, hospital indemnity plans, workers' comp, any of that stuff does not count as minimum essential coverage. Is anyone accepted from this or exempted from this? Yes. There's a number of ways that you can be exempted from this mandate as an individual. If you can demonstrate it's unaffordable, which means that it exceeds 8% of your income to pay for your medical premiums, you're exempted. If you're below the income tax filing threshold, you're exempted. If you're a Native American, a prisoner, undocumented alien, or if you have a short lapse, which means less than 3 months in coverage, you're exempted. So as long as you don't go without coverage for more than 90 days in a year, you're fine. And then there's certain religious exceptions as well. So there will be some people that do not, where the mandate does not apply to them. But overall, the majority of Americans, it will apply to you. So what happens if I don't buy insurance? What happens if someone doesn't get it? Well, there's a penalty or a tax now, as we should call it, in 2014. And it's one of the two. It's either $95 or 1% of your income, whichever is greater. Okay? And each year it goes up until through 2016, and after that they index it for inflation. Now, looking at the numbers, I'm sure you see the major flaw here, and what the criticism is on this is that the average cost of a healthcare policy starting in 2014 is probably going to be $200–300 a month, which is thousands of dollars a year. So when somebody's looking at a tax of $95, they're spending several $1,000s on a health insurance policy. Where's the real incentive there for them to go buy a health insurance policy? Especially because they're going to be guarantee issue and no pre-existing condition limitations on these policies. So anyone can just go out and buy a policy whenever they want and get covered immediately. So there's not a lot of teeth in these penalties. There's been a lot of criticism of this. How it's going to play out, whether it's going to be enough incentive for people to buy insurance, I have no idea. We'll just have to wait and see. But this is the way that it's going to work starting off in 2014. Now, the employer mandate works a bit differently. The employer mandate applies only to employers with 50 or more full-time employees. It does not apply to small employers. Now, just because there's not a mandate and penalties for small employers does not mean they're going to be impacted this to some degree, because they're still going to be competing for the same labor and talent as the large employers. And the larger employers, the 50 plus employers, are going to be mandated to provide coverage. So there's going to be a little added pressure for small employers to provide coverage, but there's not going to be a mandate with penalties, okay? But for employers with 50 or more employees, they're going to be required to provide group medical coverage. Now, how does someone determine what 50 full-time employees means? Well, they basically said that if an employee works 30 more hours a week, that's a full-time employee. So basically they have to average that in a month. Well, there's been a lot of questions as far as how employers are going to measure that. And basically what the government's done is they've established what's called a look-back period, which is what they're calling a measurement period. They're saying employers can go back 3 to 12 months, look at what the hours their employees work, average it out, and if they average more than 30 hours a week or more, they're a full-time employee. And then once you determine they're a full-time employee, there's what's called a stability period. And that's the period of time you have to offer coverage to those employees if they qualified as full-time during that measurement period. And that stability period is basically going to be determined upon what your measurement period is. Okay, so whether you use anywhere between 3 and 12 months to look back is going to determine how far ahead that you have to provide coverage. And that the stability period is going to be a minimum of 6 months up through 12 months. So once an employer determines whether or not they have 50 or more employees, then they need to decide whether or not they're going to offer coverage. So the best way to describe how this employer mandate works is to start with the best case scenario when we're dealing with this slide. And to do that, we'll start from the top left and we'll work our way down, okay? So if you have at least 50 full-time employees, if you offer coverage, if that coverage provides minimum required value and it's considered affordable, as an employer, you're in the clear. However, if you don't meet all of those criteria, that's when you start getting into penalty country. So there's a couple new terms I just introduced here. One was minimum required value and affordability. Minimum required value, this is what the government has said, that the plan has to meet this minimum required actuarial value to be considered minimum essential coverage. And what that means, basically, the 60% actuarial value is the plan has to cover on average 60% of the medical costs for the person on the plan. They haven't established the exact firm guidelines on exactly what these plans are going to look like. We have a pretty good idea of it. We actually have actuaries at our company where we're able to look at our clients' plans and be able to make a determination as to whether or not they're within that range. Nothing guaranteed because we don't have the firm guidelines. We're still waiting on those. But like they're saying, about 98% of all plans right now for group medical coverage meet this requirement. Affordable. Affordable basically means that the amount the employer requires the employee to pay cannot exceed 9.5% of their income. So as an employer, whatever you require that employee to pay, if that amount exceeds 9.5% of what they make, then it's not going to be affordable. You have to keep it under that amount in order for it to be considered affordable. So starting back up at the top, we went through the best case scenario if you meet all these requirements. Well, what if you have 50 full-time employees and you do not offer coverage? What happens? Well, basically what happens is you have a $2,000 penalty for every full-time employee, minus the first 30, if at least one full-time employee receives premium assistance. That's a mouthful, right? Well, what exactly does that mean? Well, basically, if you have, let me give you an example. If you have 100 employees and you don't offer coverage, and one of those employees out of the 100 goes to one of these government exchanges that are going to be set up in 2014, and we'll get into and explain exactly how those work. But if one employee goes and gets premium assistance or a tax credit on that exchange, you're going to be penalized $2,000 per employee minus your first 30. So if you have 100 employees, you're going to be penalized $2,000 times 70. So it's going to be a $140,000 penalty a year you're going to pay as an employer. Okay? Now, if you do offer coverage, but that coverage doesn't meet that minimum required value standard or it's not affordable, then you face another set of penalties, which is either the lesser of these two, $3,000 per full-time employee that goes to the exchange and receives that premium assistance or tax credit, or $2,000 per full-time employee, the lesser of the two, okay? So the key here as an employer is, first of all, whether or not you're going to offer coverage. You need to decide whether or not that you'd rather pay the penalty or whether you'd offer coverage in the cost-benefit analysis of this. But if you are going to offer coverage as an employer over 50, you really need to make sure the two key items you need to focus on is the affordability and that minimum required value. Those are the two key items that are going to keep you from getting penalized and taxed. And those are the two items that you have control over as an employer, okay? So, and we'll talk a little bit more about this as we go through this. So, from an employer's perspective, again, you really need to be looking at the affordability factor for your employees. Getting that plan with that minimum required value is not going to be such a challenge because in 2014, insurance companies are going to be offering plans below that threshold because it's not going to qualify. No one's going to buy it. It's not going to keep them out of getting the individual mandate tax. It's not going to keep employers out of getting penalized. So there are really not going to be any plans like that. That's not really the thing that you really need to be focused on, the affordability factor and what your employees pay. Now, premium assistance, I mentioned this, with the tax credit. What does it mean? How does it apply? How do you get it? Well, for an individual to get this premium assistance or tax credit, they have to qualify for a number of things, as you'll see. There's several different things, and every one of these they have to meet. There's only one that you can control as an employer significantly to make sure that they do not go to the exchange to get premium assistance, okay? Because that's what your goal is, because when you get someone that goes to the exchange, that's when your penalties kick in. And the first here, which I've underlined, in order to qualify for premium assistance, an individual must not be eligible for an employer-sponsored plan that is affordable and has minimum value. As long as you take care of that one bullet item, you're fine as an employer, okay? Because you'll see the other items you don't necessarily have control over. The next is having a household income between 133 and 400% of the federal poverty level. The next is they can't be eligible for Medicare, Medicaid, CHIPS, TRICARE, VA, or any other benefits of that nature. They have to be a citizen or a legal immigrant. They have to be a resident in the state where the exchange is located, and they have to buy a plan on the exchange, okay? So, you can't control whether or not they're eligible for other benefits or whether they go to the exchange and buy it, but you can control the cost of that plan and what that plan offers. Now, the premium assistance, I don't want to get too complicated in this because it is kind of complicated. But the premium assistance is basically based on the cost of the plan on the exchange and what the person makes. And it's a combination of the two, and it's a sliding scale. It starts at 2%, goes to 9.5%. And that 2% to 9.5% basically means that that person is not going to pay any more as a percentage of their income for their premiums than that. And the 2 to 9% scale is based upon what they make and how they fall within the federal poverty level. So if they're within 133% of the federal poverty level, they're going to pay no more than 2% of their income for their premiums. If they get up to 300 to 400% of the federal poverty level, they're not going to pay any more than 9.5% of their income towards premiums. So an example, there's a family of 4. They make $70,200 a year. They're in the 300 percentile. So that means they're at the upper echelon of that scale. They're at 9.5%. That means they're not going to pay more than 9.5% of that 70 grand, 70,200 for their premiums, which happens to be, their premiums are $11,000. They're not going to pay more than $6,669 for that plan. The government, or us, will pick up the tab for the rest to make up the total amount of the $11,000. So essentially, there's a sliding scale based upon their income as far as the maximum amount they'll pay, which is going to be 9.5% of their income. Now, the good news is for employers is that most individuals who are eligible for group coverage are not going to be eligible for the premium assistance because most plans are going to be affordable and most are going to meet that minimum required value. And I have some examples here, or an example here of a company I put together. It's called Happy Company. And they offer a group medical plan. It meets that 60% actuarial value, okay? And they contribute 75% towards the employee's premium. They contribute nothing towards the dependent premium. And that's something that I need to focus in on as well, because the 9.5% threshold that the employee has to pay where it becomes unaffordable, it's just for their premium. It does not include their dependent's premium, what they have to pay for their spouse, their kids, whatever. It's just the portion for the employee only. So in this case, it's a $400 a month premium for the employee. They're paying 75% of the cost, so they're paying $300 a month. The employee's paying $100 a month, okay? And you can see no matter what tier they elect, if they add their dependents or whatever, the employer is only paying $300 a month. So in this first case scenario, here's Arthur Analyst, okay? He has employee-only coverage. He makes $44,000 a year. He's 404% of the federal poverty level. Because he doesn't fall within that 133 to 400% to qualify for the premium assistance, there's no penalty to the employer because he can't go get premium assistance. So the moral of the story with this slide basically is that if you have higher compensated employees and all of your employees are outside of that range, you're going to be safe as far as penalties and anyone going to the exchange. Now the next slide is a little bit different story. We have Johnny Janitor. He has employee-only coverage. He makes $15,000 a year. He's at the very bottom of that scale. He's at 138% of the federal poverty level. So what happens with him? Well, his $100 a month contribution is less than 9.5% of his income. So as a result, there's no penalty to the employer. Third example, Annie Admin. She has employee-only coverage. She has an annual salary a little over $27,000. She's within that federal poverty range to qualify for premium assistance. However, it's still considered affordable because that $100 a month does not exceed 9.5% of her income. So this next slide, just to kind of demonstrate this, you'll see Johnny Janitor and Annie Admin, and you'll see where Happy Company contributions fall within that 75% range. That's what they're currently paying now. Well, you'll see once it starts becoming unaffordable for Johnny Janitor, it's around 70%. So if they start digging below that in their contribution, that's when it's going to become unaffordable for him. But you'll see any admin who makes more, the threshold is a lot less. It's in the 40 percentile range the employer has to pay, which insurance companies require you to pay at least 50% anyway as an employer, so that's not even an issue. The purpose of this is just to kind of demonstrate the thresholds of where you're going to have to be as an employer and the things that you're going to need to be looking at to determine affordability. You're really going to need to be looking at your lower and your lowest income employees and what they're making and whether or not they're going to be within that 9.5% threshold. You need to make sure you keep it above that. So, from an employee's perspective, they're going to have a much different perspective in 2014 than they've had in the past. In the past, they basically had their employer coverage or their individual or through their spouse or through Medicaid or whatever, and those were basically their choices. Well, now they're going to be looking at their income, the affordability of this plan, how much it costs, the value of it, and then they're going to be looking at the exchange, whether or not they can get premium tax credits and what they can do. So they're going to have a different set of options here, and they are going to be aware of the exchanges because employers are going to be required to give notices to all of the employees about the exchanges. Let them know how they work, let them know that they're going to be eligible for premium assistance, and all this other good stuff. So don't count on the employees not knowing what's going on. They're going to know, and they're going to be looking, and they're going to be aware of what their options are. So what are these exchanges that I'm talking about? Basically, an exchange is going to be run by the states or the government, and it's going to be a place where individuals and small businesses can go buy private medical insurance. There's going to be a call center, there's going to be a website, there'll be navigators to help them through it, and again, the employer notice where you're going to have to make them as an employer aware of these exchanges. How exactly does it work? Well, it's going to, at first in 2014, be available to small businesses and individuals. In 2017, large groups, states are going to have the option of allowing large groups to join in. They're going to be able to go to these exchanges and buy private medical insurance. There are going to be set plans that are going to be available on these. You'll see they start at a bronze, silver, gold, and platinum. And these are all based upon that actuarial value I mentioned earlier. The bronze plan is going to be the 60% actuarial value. That's going to be the lowest plan offered on the exchange. Now you'll see there is a catastrophic plan. That's going to be available to younger people and people on a temporary basis. So it's not going to be something that's going to be available to everyone. But once someone goes to the exchange and they look around, kick the tires, see their options, they can purchase private insurance, and then they can go see the doctor, hospital, whatever, and they have their coverage. What are the rates going to be on these exchanges? That's been a big question that everyone's been asking. Well, the rates inside the exchange are going to be the rates that they're going to be the same as the rates on the outside of the exchange. So whether or not you come to someone like me and purchase your insurance as a company, or whether or not you go to the exchange, you're going to pay the exact same price. And now this is small group. This is not large employers. This is for small group or individual. And they're going to be community rates. That's going to be a big change that a lot of people really haven't looked very closely at. Oops. got ahead of myself here and already got a laugh. Thank you. Community rates. So basically, where was I? Oh, purchase inside and outside the exchange. Okay? So, as it stands now, you know, everything's different. But when you go to the exchange or whether you come to me, you're going to pay the same price for that plan, small group and large group. Now, the community rates, basically, that's something that not a lot of people have really looked at and talked much about. But it's a big deal because this is going to affect everybody, the small group and the individual market. Everyone's going to be sharing in these rates now. There's going to be these blended rates. No longer are health conditions or gender or anything like that going to apply. So you're going to see a major shift in the cost structure for these rates. And a couple slides up, we'll talk about that. They haven't gotten the rates firmed down yet. They're working on those, so we expect them to be coming out closer to 2014. The exchange is going to determine the eligibility of someone to get premium assistance. So when someone goes on the exchange, they're going to talk, they're going to ask a series of questions, they're going to have all this information, and they're going to be able to determine whether or not that person's eligible for that premium assistance or tax credit. And no wrong door. Essentially what that means is that when they go on the exchange, they're saying that when that person leaves, they will be put in a policy or taken to where they need to get a policy. So if they get on the exchange and say, no, you need to go get Medicare, they're going to steer them to Medicare and help them get signed up to Medicare. If they say, no, you need to go to your employer, they're going to steer you to your employer. If you get premium assistance, whatever. They're supposed to take care of everything when you get on the exchange and make sure that you get medical coverage. Now I say set up by each state because that question comes up, you know, all the states, you've been hearing a lot of roar, especially in Texas. It's like, well, what are we going to do in Texas? What's going to happen? Are we setting up an exchange? And of course, that's the slide you already saw, right? Well, Rick Perry says no. And that, I love this slide too, because whether you love Rick Perry or you hate Rick Perry, you love that slide, just for completely different reasons, right? I love it. So yeah, Rick Perry says no. We're not setting up an exchange. We're not going to participate in the Medicaid expansion. We're not doing anything. Well, what does that mean for us? What happens to us in Texas? Well, essentially what that means is the federal government's going to come in and set up their exchange force. And they're going to establish all the guidelines and rules revolving around the exchanges. What's that going to look like? I have no idea. Is that a good thing or a bad thing? I don't know. But there are a number of, we're not alone. There's a number of states doing what we're doing. And I know you probably can't see all this, but every different color is basically a different status of the states. Running from plans to establish, to already established, to decision not to create, to no activity, to just studying options. So the point of this slide is it's a mixed bag. And there's a lot of people that aren't even anywhere near close, or haven't even started, or just said they're not going to do it. So what does that mean? You know, when you have all these states that aren't going to set it up and then it's all been thrown on the federal government's lap to set them up, highly unlikely everything's going to be running like a fine-tuned machine come 2014. So we're just going to have to wait and see what happens and what these exchanges are going to look like, and even if they're up and running correctly by the time that happens. So, community rating. I mentioned that. What does that mean? This is going to apply to small group and individuals. And essentially, what it means is that we're all going to share in the cost for the most part from this point moving forward. So health conditions and gender are no longer going to apply. So this guy on the top right-hand side of the slide, this big muscle guy who takes care of himself, makes all the right decisions, is going to pay the same amount for the insurance as this guy on the bottom left who doesn't make the right decisions. Some people think that's good, some people think it's bad. You know, it's just the way that it is now. There's going to be certain exclusions. Tobacco use, they're going to be able to rate for tobacco use, family size, geography, and to a certain degree age. And that's a big deal. The age is a big deal because the maximum factor is 3 to 1. And looking at it actuarially, from the lower age demographic, non-Medicare age, to the higher age demographic, it's about 5 to 1. And so as these actuaries are putting these rates together, they're finding out that that age bracket from about 18 to 35 is going to pay about 40% more for the for the individual and group medical premiums on small group. That higher demographic, 50 to 64, is going to pay about 12% less. So what you're going to see is the major cost burden shift to the younger, healthier people. Now, who are the largest number or a big segment of the uninsured right now? They're the younger, healthy people who don't buy insurance. That's 40% cheaper right now. So when 2014 rolls around and these people see their rates go up 40%, and then they're staring down a $95 a year penalty, we'll have to wait and see what happens and what that's really going to mean and whether or not people are going to be incentivized to get insurance. So this is going to apply to small group and individual coverage. Now, another thing coming up, reporting of health insurance coverage to the IRS. Any employer that's a large group or that offers group medical coverage is going to have to report to the IRS whether or not an employee can enroll in minimum essential coverage, what the waiting periods are, what the premium cost is, what the employer contribution is, and the number of full-time employees. And this starts in 2014 as well. So this is a new reporting requirement that all employers are going to have to submit to the IRS. Automatic enrollment. This is something that's been put on hold. It's supposed to start in 2014, but they found out that it's just not going to happen in time. So it will probably happen sometime in 2014, but all employers with over 200 employees are going to have to automatically enroll all their employees in the group medical coverage and have a system set up to do such. Patient protections, I mentioned this already, or one of them, but starting in 2014 as well, an employer cannot make an employee wait more than 90 days to get on the coverage. And so no more of this first of the month following 90 days, which some employers have or anything like that. It's just 90 days. So as an employee or employer, you need to be aware of this upcoming change. And also elimination of pre-existing condition limitations. Right now, it's up to age 19. There's no pre-existing condition limitations. But starting in 2014, anyone that gets on a plan, you're covered immediately. So no more waiting periods for anything. Also coming up, actually already in place, the PCORI fee. It used to be called the Comparative Effective Research Fee. They actually talked about this last night, and they've talked about it in debates. It's a hot topic. This essentially is any employer that offers group medical coverage, they're going to have to pay a fee of $1, starting this year, of $1 per covered life. That's not per employee. If someone's enrolled with 5 people on the plan, that's $5 the employer is going to have to pay for them per year. This is a fee that goes to the government that they use to basically compare and research outcomes and procedures and how they work and what's effective and what's not. Now, what they're going to do with this information and how they're going to use it, that's been what the big debate is. They say they're not going to use it to ration care. You know, I'm not sure, if they're not going to do that, what the purpose is, but they're going to take that money and use it for that. Now, starting next year, it's going to go to $2, and then they're going to index it accordingly for the future as it goes on. So if you're fully insured and you have a fully insured plan, the carriers are going to bill you that money in your invoice. They're going to collect it and submit it. If you're self-insured, as a lot of large employers are, you're going to have to file that and submit that payment to the IRS yourself. Next year, these are upcoming tax increases, or again, as I say, revenue generators. Next year, the Part D drug subsidy elimination. These are for employers that offer retiree coverage that pay for Part D drug subsidy, or pay for the Part D drug coverage for those retirees. The federal government was subsidizing and helping pay for that for these employers. That's going away. They're no longer going to do that. The Medicare tax increase. This is going to apply to everyone that makes over $200,000 a year filing single, or $250,000 a year filing jointly. I believe it's 0.9% increase over what they're currently paying now. And the itemized medical expense deduction changes. Currently, as it stands now, any medical expense that you have that exceeds 7.5% of your income, you can itemize and write off your taxes. Starting next year, they've raised that threshold to 10%. So you have to have your medical expenses exceed 10% of your income before you can start writing those off. The Cadillac tax. This starts in 2018 and applies mostly to unions. When you look at the date 2018, I think you can kind of look at the election cycle and determine why that kicks in 2018. Essentially, what it is for these very expensive, very rich plans, mostly collectively bargain plans, if the amount for the individual is over $10,200 a year, or $27,500 for a family, any amount over that's going to be taxed at a 40% rate. Okay, and that's another revenue generator slash tax increase to help fund this bill. So, going through all this, what should employers do now? What I tell everybody, I think you can see by going through all this stuff and us just scraping the tip of the iceberg that it's extremely complicated and difficult to keep up with. Make sure that you are receiving expert counsel. And I'm not up here self-promoting myself or anything like that, but you need to make sure that whoever you're working with on your group benefits is keeping you ahead and not just kind of reacting as things go along, making you aware of all these things. You should be preparing and doing these things now and have the tools and resources and guidance to make sure this is happening. Don't wait till October, November of 2013 and start scrambling to figure out what's going on, because there's a number of things that are already in place that you need to be doing, and there's a whole bunch of stuff you need to be planning for coming up down the road. You need to be determining your health plan strategy as part of your total compensation. You need to be looking at whether or not you need to be providing coverage. What benefit is it if you do provide coverage or don't provide coverage? Is it of value to you? You need to be performing a quantitative and qualitative analysis on your different approaches. We have tools that we use for our clients where basically it's a pay or play deal, where they can punch in the numbers and say, this is what's going to cost me right now if I don't provide coverage. This is what it's going to cost me if I do provide coverage. Here's what's going to cost me if I provide coverage, but I only pay X%. So they can run the numbers and see, well, how am I going to be penalized if I have a few employees that fall above that 9.5% threshold? You need to be looking at the numbers and making a determination what's going to happen, and not be getting any surprises when 2014 rolls around. You need to be learning about and preparing for the private and public exchanges. There's going to be private exchanges competing with the public exchanges as well. They're already setting these up. We actually have one in Oklahoma and Pennsylvania we're test driving, and we're bringing to Texas here soon. But we're going to be competing, and brokers are going to be competing with these public exchanges with their own private ones. Really the main difference between the two is that you're not going to be able to get premium assistance or a tax credit through the private exchanges. But outside of that, I believe the private exchanges are going to be superior because they're going to be offering a lot more products. You're not just going to be buying medical. You're going to be able to buy dental, life, disability, all those things on there as an employer and individual. So those are going to be out there, and keep an eye out for those, because those are going to be a viable option to the public exchanges. Even though I said you need to have counsel and people keeping you up to date on this, you need to be staying up with it yourself. Pay attention to all these things that come out and just keep an eye on them, because you need to make sure that you understand what's happening. And develop an implementation and communication plan. You need to make sure whatever you do, you're maximizing your results on it, communicating it to your employees, and getting it done. Department of Labor audits. This is something, I mentioned as far as just keeping up with everything. A big part of this bill is they funded the Department of Labor a lot of money to go out and audit companies to make sure that they are compliant with PPACA and a lot of the other regulations that even came before PPACA. Before, the Department of Labor was complaint driven. If someone came to them, an employee came to them and said, hey, look, I've got an issue here, then they'd come in and audit. But now they're just randomly auditing companies. And they're not auditing certain types of companies or sizes of companies. We've had 7 clients of ours in the last 6 months that have been audited by the Department of Labor. Basically, they get a phone call and a letter saying, we're coming on this date, you need to have all this stuff ready for us, we want to look at it, make sure you're doing it. We want to make sure you're sending all the required notices to your employees and you have documentation of it, that you're providing their summary plan descriptions and providing proof that you've provided that you're complying with HIPAA, that you're complying with PPACA, that you're doing all these things. We want the name of your CPA, your attorney, your broker, all this stuff. And they're coming in and auditing these companies and making sure they're doing all these things. So thinking that you can just kind of skate by and not pay attention to this stuff, they're out there and they're looking, and you're definitely going to see more of this going on. So make sure you're prepared and you have everything done and you're in compliance. Now, the future of PPACA politically. I know Doug spoke on this a little bit when he came up here before me, but the future is still fairly uncertain. We have the upcoming political elections, right? There's been a number of attempts to repeal and replace it and talk about that, but because the houses and Congress are split, it's not going to happen, right? Until we have a majority of Republicans in the House, there's no opportunity for that bill to be repealed and replaced. So until the structure of the House and the Senate changes and the presidency changes, it's going to stay in place and remain as is. There's been a number of attempts to defund the bill or scrutinize the process, to delay funding, all these things. You'll see these happening, and they've been happening, and they'll continue to happen as well. So depending on how effective they are and what they can do, we'll just have to wait and see. There's also the states. We have Texas. There's a lot of states that are opposing parts or all of this. And so those are other things that we're going to have to wait and see how they play out. For example, with us, what's going to happen when we reject the exchanges? When the government comes in, what's it going to look like? What are they going to do? Are they going to do it in time? We really don't know. And then, of course, the presidential elections. President Mitt Romney, what's that going to look like? He's basically said he wants to repeal and replace it. But again, without a majority in both houses, it's not going to happen. So what can he do if he gets into office, and how can he change the face of this bill? Well, I mentioned before, those over 1,000 times it says the Secretary shall determine. Well, right now, President Obama's Health and Human Services Secretary is making all these determinations, granting all these waivers, and establishing all of these guidelines. Well, when he gets into office, what he can do is he can appoint his own Health and Human Services Secretary to go back in and change and reestablish and alter and modify all of those guidelines that have already been put in place. So what we may be looking at is everything changing again. And not that it's already difficult as it is, and like hitting a moving target right now. If Romney gets into office and doesn't have both houses, we're going to see significant changes probably in this. Now, what he's going to be able to do, what the political will of the people are, and how that's going to drive it, we're just going to have to wait and see. But I would expect to see changes in the bill and several significant things removed or granted waivers or whatever on. How employers are going to react. There's been a lot of talk about this. A recent study came out that said 1 in 10 employers said that they're just going to drop coverage when 2014 hits. That was 3 out of 10 a year ago. So the numbers have changed. As far as what exactly is going to happen, it's really hard to tell. I think we're just going to have to wait and see once everything's put in place. And I think that's what employers are mostly going to do. They're just going to keep doing what they're doing. You may have a few change their path, but once everything gets in place and they see how this is going to affect everything, is really the only way we're going to be able to see what exactly happens. Again, this is just a reminder for me. Just make sure that you are getting everything that you need. Make sure you're getting up to date, you're getting regular updates, you're getting good guidance and compliance on what's going on, because, the future of healthcare has changed. No matter what happens with the political elections, no matter what happens, the days of the group medical insurance where you just go out and you shop your policy and get it, just hand it to your employees, it's over. You need to make sure you're staying on top of these things, because it's become increasingly difficult, and it's only going to get more and more difficult as time goes on. So that's what I got. How'd I do? 3 minutes? Any questions? Hey, there we go.
What's the effect of health savings account plans going to be? This money already paid in health savings accounts, is that going to continue? Or? Yeah,
that's a great question. That's on an individual or small group basis. That's where you saw that catastrophic plan is going to be available. That would probably, and I say that because there's so many gray areas, where those health savings accounts are going to fall. From an employer perspective, they're still going to be able to offer them on a large group. Because I asked that question. I'm on an HSA, and we are a large group. And I said, well, what's going to happen? Am I going to lose? And they're like, no, that's only for the individual and small group. That's a good question. And they raised the HSA penalties. I think it was on that slide. So if you remove your money and pay for something not medical related out of your health savings account, or you take it out early or whatever, your penalties have increased on that starting this year. So there can't be just one question. For their family members, no. It's just them. It's just the employee. Yes. Good question. Thank you. Yes?
If the employer is penalized at $2,000 per employee, is that tax deductible to the employer, or is it just simply an out-of-pocket expense?
I spoke on this subject on Tuesday to another group, and that question came up because, the Supreme Court ruled that it was a tax. But that was for the individual mandate. They didn't rule on the employer mandate whether that was a tax or a penalty. And that's a good question, because if it's a tax, then it is deductible. If it's a penalty, it's not. And the assumption that's being made at this point is that it's a penalty, it's not a tax for the employer, and therefore, no, not tax deductible. But that could change, because everything has since this bill was signed into law. Anything else? Got time for maybe one more? All right. Well, thank you guys. I appreciate it.